dignitaries. After lecture of such a giant, of such a giant, I am feeling like I am nowhere around. I have walked a little distance in AVN, and it is something like it's never told before in orthopedics. So I have just you can say few cases that have to be shown, or per se total number is very less. But the thing is, like it's a quite promising thing you can offer to a patient till stage 4. Case that has been operated multiply. First patient has a busy cervical neck fracture, and then it was fixed with a PFN. Usually we do when it's a busy cervical, people do it. That got infected and that also went into non-union. So the second surgeon extracted out that PFN, infected PFN, and given some window period for say 2-3 months, and he was again operated with 90 DCS. The fracture was healed totally, but the patient got AVN hit. This one, and there was not much of infection dwelling around. So I done the pedicled vascular iliac crest graft. We will understand after some pictures this, but see the healing, level of healing. This was after something you can tell about 4 months of X-ray, and this is the final X-ray. After it, you can say 2 years, 2.5 years, and this is the movement of that chap. That's almost 20 years young, a young chap. The thing, this methodology has been never understood, but the thing is, you have so many vascular bone grafts around the hip. There is peri-hip vascular bone grafts. Uh, I will not go into the complex nomenclature of that, but will try to make you understand a little bit. This is external iliac artery. This artery you are watching is called DCIA, deep circumflex iliac artery. This artery is, in some cases, it arises from SCIA. This artery. These are the base arteries of some you can tell popular flaps around the abdomen. Artery that is taking origin below just from this external iliac only. This one is the inferior epigastric artery. That is the base of abdominal flap. And artery above that goes into the iliac crest. You can take this bone out from this, have a careful dissection till this, and you can push that segment to below. Same like this animation. With bone, with artery, you can pull that vascular bone graft in the neck of the femur, because this is very nearby. This femoral artery is hardly per se 1 or 2 centimeter away from the femoral artery, and this much flap is enough to push it into the neck. So it is pedicled iliac crest vascular bone graft for avian hip. This looks something like this. Incision comes like this. Per se, you have to put a drawing on the exactly on the femoral artery. There are many methods. For this, you have to learn a dissection. Same thing like the plastic people do. It's a very classical. Actually, the thing is, as I had started, I had a limited or a few data. So from the next time when I will get a patient, I will keep the full pictures, everything. But at this stage, you can understand that the incision is put already over the femoral artery. Then you can curve it over the iliac crest, and from there we can open that artery. We can trace these arteries in an anterograde fashion from the femoral artery towards the iliac crest. One or two case you will do it fantastically. Meanwhile, you may need a surgical microscope or a loop, but these are not something you can tell that rocket science. So this can be taken the same approach. Sir told it. This is trapdoor neck. We have drain out almost the bone graft from inside. and this iliac crest bone graft we have to push it into it. Mostly if we take even a heavy sutures like that you are using for this arthroscopy or like that, or nothing is available, then you will take a suture with this vicryl one, then even it's okay. There is no problem because vascular bone grafts are takes up very fast. Probably you may have not seen that my lecture. I am employing this into recalcitrant non-unions of different bone also, complicated traumas also. And I had taken a talk on AOCD, that unusual orthopedics, in the name of unusual orthopedics. Almost non-union and fresh bad trauma healing time is 1.5 months with this blood supply. You can see that lecture also. If anyone is interested, I will send the YouTube link. So the thing is, vascular bone grafts take up very fast. Yes, there may be failures. There may be failures like other surgeries. But in the patients who in which it's taken up, it's the cortex swells like anything, and healing is very fast. So this is pedicle graft, and if I show it with animation, it's becoming little heavy. So if I will show it with animation, it's something like this. Second case, fracture neck femur, same basis cervical, and I am very fond of this instrument. This is a magical instrument. Magusar also tells many times. If you get anything complicated around the hip, per se it's a complicated femur, per se it's a neck, per se it's a subcapital fracture. When you give a valgus na, actually I have done 3-4 cases, and I am employing into this what you can tell that failed PFN or failed even trochanteric plates and all that. But I don't remember that it has been failed any time. There is not a single failure. Per se case number is very less. There may be 7 to 8 cases in the proximal femur, including necks. But it works very magically. But when you combine it with this magic, this another magic, this vascular bone graft, it heals very faster, and actually I have not this photograph of this patient because I operated when I started doing these things around 5 years before. But the thing is, you can also take a periosteum from the place where you take iliac crest, and if you put that periosteum around such a fragments, probably anyone can point out to my mistake that it has been not compressed very well. Yeah. Many people can expect that there may be failure. Obviously, if there is a valgus, there is no failures, but still it may fail. But the problem is, I have wrapped around this after trap during it the vascular bone graft. I have wrapped it around with this this periosteum, and probably you won't believe that the periosteum creates a calcification or a callus very faster than the bones. Very faster. It swells up like anything. You say this is all healed in just 2 months. It's a thing like before patient do something bandarbaji or like monkeyness, the bone heals. If they start weight bearing in just 1.5 and 2 months, then even it's okay. Most of the time, if you have such a destruction or a like that, it may give out of the give way to the implant. But the things are such a faster that with this bone graft that before patient performs something, it gets healed nicely like this. Per se, you will feel that I am going from AVN to neck femur and neck femur to AVN, but these are both dreaded complex problems of orthopedics. Even proximal femur is a quite a complex problem in orthopedics. So we can anytime pull our leg out of the hole if we know such a things that even previous implant has been done, it's a failing, then we can adapt this. If the neck has got avian after screws, we can put like this. Uh, this is probably the photograph of incision. This fellow had a very complex deformity. Same procedure has been followed. That we have pulled out that iliac crest bone graft and put out in the neck place. This is the video. This fellow has a severe bow legs from mid femur. He is a fluorotic person, so he is not able to squat or a stand. But if he would have not deformity in the mid femur, he easily have squatted or seated on the ground. Last but not least is the FVFG. Yes. Per se, you have a very much damage in the avian per se grade 4. Then there is something like a multiple perihip bone grafts. We also pull out the BCIA based vascular bone graft. We also pull out SCIA based vascular bone graft. We also pull out lateral circumflex femoral artery based vascular bone graft and reconstruct the head. Actually, I have not got availed such a patient to operate, but it's with permission of operator. See, whole head is gone. These are though these are all Chinese papers, but still see, and as a trapdoor, whole head is open and dislocated. Most of the bone is removed from that. Impact that bone graft and do multiple that vascular bone grafts. And these are the matters of 2 to 3 months only. It swells up and it catches the cartilage. And why this perihip bone grafts? Very popularized surgery in an avian hip is microvascular fibular bone graft. One case is coming behind. But as an initial period, I had learned that the first case was I had done around 5-6 years before was a microvascular fibular bone graft. That was done in a stage 3. James Urbaniak tells that it's per se real indication is still stage 2 when there is no this collapse in the avian hip, right? But at that time when I was learning this, I was not aware of this perihip graft. So at that time I was knowing just fibular bone graft, and still it has recovered. After the learning all this graft from various faculties around the world, when there is a collapse, I use perihip graft. So the articular surfaces are A-like. It's not like, but it's A-like, and it constructs the head. And as Madhu sir told that a complete congruent head is not needed for walking. Just any sort of collapse is below that articular surfaces is okay. People are living with that. So we can give such a fantastic thing to the patients, and I agree that THR is not a bad thing per se. THR as a surgery is a surgery of the year, but the revision and re-revision THRs are obviously complicated procedures, and in reality, if I go through US or any developed countries joint registry, a complication up to 50 to 60% are noted, and see the graveness of that complications. A surgery after surgery, every time there is loosening, every time 6 monthly or 8 monthly there is a surgery, either liner goes away or a stem goes unfit, and the patient is almost lame. It's just a thing like we cannot advise him a amputation in a front pose, and these surgeries are like to save ourselves, that we don't want to advise her or him an amputation.
Sir,
But
please conclude.
yes, sir. Last case, very fast. I will go through. This is a microvascular fibular bone graft, avian grade 3. Fibula is extracted out with its vessels. Its drill is the trough is drilled. Fibula is put inside, wired, and these are the results in a grade 3 even. Now, 5 to 6 years post this surgery, now patient has got arthritis, but it's a good delaying procedure for him also, and still the patient is good. faster last stage of this surgery is just check out blood from fibula and see for the anastomos probing at the anastomos vessel. See this. I can send these videos to personally also. So it's a fantastic. These are all fantastic surgeries and works in most of the cases. Not in every cases, but most of the cases. And my conclusion is also same like Dr. Madhusar's conclusion, that try to preserve the hip as fast as possible. THR is not a complicated procedure, but revision and re-revision THRs are obviously complicated operations. I also do this same thing and have planned to do all these things. If anyone have a patient and feels like that how I completely cure and avoid THR, they can send it to me with confidence. So conclusion is same like we are doing it till stage 4 and we are giving approximate surfaces to the patient with which Indian patients, Western patients a little plain and gets converted into THR, but Indian patients with a little pain, it's okay and they want to run their hip, their own hip. So such a patient can be a right candidate for this, and it's a very good, you can say, a very good procedure and with a higher success rates. In the even stage 3 and 4, the success rate is around 70%. Those have done this ZH and all have done. They have 3,000 cases, and out of that, some 2,500, 2,400 are doing well. So thank you. Thank you, friends, and thanks a lot to all dignitaries for giving me this opportunity. Thank you, sir.
Thank you, Ramesh bhai.
And now it is time for the organized himself.
Thank you, sir. One thing that we have a mindset looking to the X-rays of Magoo sir, that we imagine that this hip and no pain, is it possible?